Welcome to this explainer. If you've ever stood at a patient's bedside feeling totally overwhelmed by all the dials, the acronyms, or the math behind CPAP and BiPAP machines, well, you are in exactly the right place. We're going to make it all crystal clear today, so you know exactly how to help your patients breathe a whole lot easier. Okay, let's take a quick look at our roadmap for today. We are covering the respiratory stepping stones, the core basics of CPAP versus BiPAP, the math behind the masks, how to adjust those dials, when to use which device, and finally, we'll be busting the aspiration myth. All right, let's jump into section 1, the respiratory stepping stones. Where exactly do we stand? To really get these masks and understand what they do, we first have to see where they actually fit in a struggling patient's treatment journey. Context is literally everything when we're escalating respiratory care. So think of it like an escalation ladder. We start simple, right? Just a standard nasal cannula. If the patient needs a bit more support, we step up to face masks or non-rebreathers. But what happens when we have to push just a little bit past that point? That's where non-invasive positive pressure ventilation comes in, which includes both CPAP and BiPAP. It's our critical stepping stone, the final, vital bridge we cross right before we have to resort to full mechanical ventilation and a breathing tube. Moving right along to Section 2, CPAP versus BiPAP basics. What's the core difference? Now that we know exactly where we are on that treatment ladder, let's nail down the single most important rule you've got to remember about these two devices. It all boils down to this absolute contrast. CPAP only helps get oxygen into the blood, whereas BiPAP provides oxygenation plus ventilation. So what does that actually mean at the bedside? Well, oxygenation just affects blood oxygen levels, meaning both machines will absolutely help a hypoxemic patient. But ventilation, that's a whole different ballgame. That refers to the physical act of blowing off carbon dioxide. So if you've got a patient with COPD or asthma who is trapping all that CO2, they have a ventilatory problem. CPAP just isn't going to cut it. They absolutely need BiPAP to help them ventilate. Okay, Section 3, the math behind the masks. Time to learn the jargon. Let's dive into the terminology so we can really understand what the machine is actually doing to the patient's lungs. First up, we've got EPAP, or expiratory positive airway pressure. Now, both CPAP and BiPAP use this continuous background pressure. It's basically the exact equivalent to PEEP on a mechanical ventilator. By keeping that constant pressure in the airways, even when the patient exhales, it totally prevents the alveoli from collapsing. And that right there is precisely why both of these machines are so successful at improving a patient's oxygenation. But BiPAP takes things a step further, doesn't it? It adds a second level of pressure. This is your IPAP, or inspiratory positive airway pressure. Think of it as a secondary, much higher burst of pressure that kicks in the very second the patient takes a breath in. And this is where the magic happens. This brilliantly illustrates exactly how BiPAP provides that all-important ventilation. The gap between those two pressures, your IPAP minus your EPAP, creates something we call pressure support. And here is the kicker. The bigger your pressure support, the more the machine is physically helping the patient take in larger tidal volumes. By forcing that larger breath, we hit the ventilatory component and successfully clear out all that trapped carbon dioxide. So picture this. You're at the bedside, setting up a patient on BiPAP for the first time. You are almost always going to use this as your reliable go-to starting point, an IPAP of 10 over an EPAP of 5. Doing the quick math, that gives you a starting pressure support of 5. Which brings us to Section 4, adjusting the dials. Let's do some scenario-based math. Let's see how we'd logically tweak these numbers to treat exactly what's going wrong with our patient. Say your patient started on that baseline of 10 over 5, but they're failing to ventilate. They just can't blow off the CO2. How do we help them out? Well, we need to increase their pressure support. To do that, we leave the EPAP alone at 5, and we crank the IPAP up to 15. The new math? 15 minus 5 gives us a new doubled pressure support of 10. That higher support forces bigger breaths and blows off that stubborn CO2. Okay, conversely, what if the patient is ventilating perfectly fine, but they solely have an oxygenation problem? To fix oxygenation, we have to bump up our baseline pressure, the EPAP. Let's raise that EPAP from 5 up to 10. But hold on a second. If we leave the IPAP at 10, our pressure support drops to 0. So to keep our pressure support completely steady at 5, we are forced to also raise the IPAP up to 15. Our pressure support stays exactly the same, but our oxygen-driving EPAP has successfully doubled. And finally, the worst-case scenario. The patient is failing at both oxygenation and ventilation. Starting from our 10/5 baseline, we first raise the EPAP to 10 to push the oxygen in. Then, because we desperately need to improve ventilation too, we crank the IPAP all the way up to 20. 20 minus 10 gives us a really robust pressure support of 10, all while maintaining that high baseline EPAP of 10. Boom! We've successfully tackled both respiratory failures at the exact same time. All right, Section 5, when to use which. Let's talk clinical indications. Now that we're essentially math wizards, let's zoom out and look at the broader clinical picture. Who actually belongs on these machines in the first place? The golden rule here is that you should really only place patients on non-invasive positive pressure ventilation if they have a condition we expect to reverse rapidly. We're basically just buying time for our medications to kick in. It's absolutely ideal for COPD and asthma, where we can hit them with steroids and bronchodilators and expect a fast turnaround. It's also perfect for heart failure exacerbations, where we can give heavy diuretics, help them pee out that excess fluid, and usually see a super rapid positive recovery. On the complete flip side of the spectrum, if your patient is dealing with a slow-healing, stubborn condition, like ARDS, severe pneumonia, or a pulmonary fibrosis exacerbation, you really need to reconsider the masks. Because these conditions take days or even weeks to reverse, these patients likely need immediate intubation and full mechanical ventilation. The masks just aren't going to bridge them long enough. Section 6, the aspiration myth. Time to debate mental status. Let's wrap things up by tackling a super common, highly debated scenario that causes a massive amount of pushback in the hospital environment. Picture this. You've identified a patient who desperately needs BiPAP, but they are acting really confused. You are almost guaranteed to get immediate pushback from your team when ordering it. The knee-jerk reaction is usually, wait, we can't put a tight mask on them. What if they throw up? And honestly, that is a completely legitimate clinical fear. The anxiety is that if a confused patient throws up while strapped to a machine blasting high-pressure air into their face, that positive pressure will literally shove all that vomit straight down their airway, causing a massive life-threatening aspiration event. Nobody wants that. But here's where the clinical data actually challenges our fears. Studies have definitively proven that there is no increase in aspiration events or poor outcomes for patients with mild to moderate encephalopathy. Now, why is that? It's because a lot of these patients are actually coming in hypercarbonic. That trapped toxic CO2 is the exact thing causing their altered mental status. By putting them on BiPAP and supporting their ventilation, you actually blow off the CO2 and cure their confusion. The machine fixes the very thing we're so afraid of. So the ultimate takeaway here is incredibly simple, and it's a fantastic golden rule to practice by. If the patient is severely obtunded, completely unresponsive, and unable to protect their airway, skip the mask entirely and intubate immediately. But if they just have mild to moderate confusion and they still possess the basic motor skills to simply rip the mask off their face if they feel sick, then CPAP or BiPAP is totally safe to try. I'll leave you with this final provocative thought to take into your next clinical shift. Whenever you are standing at the bedside of a struggling respiratory patient, before you even reach for a dial or call for a mask, always stop and ask yourself, am I trying to fix an oxygen problem today or a ventilation problem? Answering that single question correctly will guide you perfectly through everything we've just covered. Thanks so much for hanging out with me on this explainer, and I really hope this empowers you to use these incredible tools with absolute confidence.